Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And here we have a patient who attended with a fully blocked right and left ear, but I'm just going to show you the right ear in this video, and I will upload their left ear separately. It's just because this video is quite long as it is. Now, this patient suffers from chronic dead skin accumulation in their ears. They only presented 2 months ago. For the last 6 to 9 months, they're having to attend every 2 months to have this cleared. I have, on a couple of occasions, written to this patient's GP to request an ear swab because I suspect the underlying cause of this patient's chronic dead skin accumulation is an overgrowth of fungi, and you'll see some of the fungi in a moment just residing on the surface of this dead skin. Now, this patient is 95 years of age. They wear hearing aids. Of course, with all this in their ears, not only are they not able to hear, but they're not able to wear their hearing aid. And initially, because this dead skin extends right from the entrance of what is a very narrow ear canal, especially laterally, to their eardrum. When I initially inserted the endoscope into the ear, because of the dead skin being right up against it, there was a bit of glare and reflection. And because they have got a bit of a narrow ear, similarly, you're going to get a bit of a glare initially. And once I start clearing away at the entrance, you're going to see, obviously, the glare will reduce. Because there's because this is dead skin contains keratin, which is a protein also found in our fingernails and hairs. And one of the characteristics of keratin is that it's highly reflective. So it actually protects against harmful UV rays from the sun. So this is a very thick blanket of skin here. And the patient has got multiple layers of dead skin. It's literally like an onion. So this is the thicker layer, and then underneath you've got several thinner layers that's very adherent to their ear canal. And the consistency of this blanket of dead skin, it's almost like rubber. It's so elastic. So as I'm pulling it, I can feel it stretch and wanting to rebound. And I'm having to really tug away at it to remove. I don't think I used a forceps because normally with forceps, with this very elastic dead skin, I might do it. I don't think I did though, because I can predict what will happen. It will just cut this dead skin. Instead of extracting it, it will just tear away little pieces. I'm wanting to avoid drops wherever possible because as this patient has hearing aids, they wanted to wear them upon leaving. So I'm trying to avoid drops if necessary as well. And the problem with drops in this patient's ear, because the entrance is quite narrow, a lot of the drops, the oil will coat the hairs. So you can see these spiky hairs, and every time I insert the endoscope, it's going to smear the lens, although I can try and navigate around or through the hairs because it's a narrow entrance, there's very little space. Now, when we write to the GP, I don't get a letter back explaining the results of the swab. So I asked the patient what their swab results were, and I think they only had the swab less than 2 months ago, and the patient hasn't heard back. So normally in the UK, any swabs or blood tests, results come back very swiftly. In fact, I went for a blood test the other week and I got my results back the following day. So it could be one of two things. That it could be that there's nothing found, but even then, typically, you do hear back from the doctors, or it's just gotten lost in administration. So I have advised the patient to contact the GP back, because it's not normal to have this amount of dead skin. And we know there's an overgrowth of fungi because we can see all the hyphae sitting on the surface of the skin. And some of the chronic otitis externa, which technically we would label this under, it's normally fungal in nature, not always, but it's normally fungal, and there's no pain. So another character, if there's a bacterial infection, you normally get a lot of pain, you get a lot of purulent discharge. So there's no discharge here really. There's no pain, but it was very itchy for the patient, which again is another symptom of a fungal infection. And so our ears is actually full of resident bacteria and fungi that live on the surface of the skin. We call that skin flora. And they seek the ear as a source of shelter and food, and then typically harmless under normal conditions. But with the fungi, the normal fungi strains are Aspergillus and Candida in the ear. And if the conditions of the ears changes, then you can get an overgrowth of this fungus, which then becomes pathogenic. And then that elicits an immune response from the ear. And when you have an immune response, you have increased blood flow, inflammation, which then promotes the secretion of more skin. And the more skin that your ear secretes, the more dead skin that you're eventually going to accumulate in the ear, because that skin is going to die and shed. And this skin is obviously not naturally migrating, partly because of the patient's age. So again, the epithelial migration reduces with age, and because they wear a hearing aid, it's preventing the skin from naturally migrating. It's somewhat pushing it back in. So I'll be honest, when I first started earwax removal, I wouldn't have dared to attempt peeling these thinner layers. Sometimes it's still not possible with certain patients. Remember, we're working very closely to the bone here, and we need the patient's cooperation. We need them to remain still. A lot of patients, when you perform, well, I wouldn't say a lot of patients, but a fair few patients, when you perform earwax removal, they can be very anxious and nervous, and that's totally understandable. I had a procedure of some sort recently, and I was slightly anxious and nervous, but knowing that I needed to remain still for my clinician who's performing the procedure, I was doing my best, and I can relate to that totally, because we're all in that position ourselves. We all sometimes have to have procedures. For example, even if you're having blood, for example, I recently had a blood test, so you've got a needle being inserted inside of underneath your surface layer of skin. So if sometimes patients are not able to remain still enough, they're very anxious, so it's not always possible to remove all these layers of skin, and there are going to be a few remaining layers. It's not possible for me to remove every single flake of dead skin or layer of skin, but you can see there's multiple layers. I remove one and there's another one. Although we know the eardrum is there at the end of the ear canal, it's not very apparent that it is the eardrum. You can't see the landmarks because there is, again, multiple layers on this patient's eardrum, and I will come back to that to remove. So this is some skin on the posterior canal wall. And then this is the layer of skin at the roof of the ear canal. And I'm using the fine end suction probe here. So this has got an outer diameter of approximately 1.27 millimeters, an internal diameter of, I think this is the thin wall one, so it's 1.02 millimeters. With your standard Zollner suction probe, the outer diameter, you get variances. It could be 2.1 or 2 millimeters. And then you can get various internal diameters. So it all depends on the wall thickness. So the standard wall thickness with a 14 gauge, which is also the equivalent to a Zollner, is around 0.2 millimeters. So if you have a suction probe with an outer diameter of 2.1 millimeters and a wall thickness of 0.2 millimeters, because that wall perimeter goes all the way around, you have an internal diameter of 1.7. So I'm currently developing a suction tip which has a smaller outer diameter, which is 2 millimeters, but a thinner wall thickness of 0.15 millimeters, which gives you the same internal diameter of 1.7 millimeters. So it's a thinner exterior, but this equivalent interior. So we're just in the process of manufacturing that. And basically all that means is that you're able, when you insert the suction probe, the Zollner, into the ear, because I know it's only 0.1 millimeters difference in outer diameter, but sometimes that can make a huge difference. So it's more streamlined and accessible into the ear, but it doesn't compromise in terms of the internal suction power, because the internal lumen, the internal diameter, is the same. Now, I've just arced the end of the suction tip there, and when I just arc it, it just enables me to perform more delicate procedures. So if I go against the eardrum, for example, that arc just assists, instead of being a straight probe, having the arc. And it's very minimal. You may not always be able to detect it. So again, I'm on the eardrum here, and I'm removing just one layer at a time. So the eardrum is becoming more visible now. I'm going into the anterior aspect, and this dead skin is a bit more mushy because of all the humidity, and once I peel this away, you are going to see more of a blue tinge, which is the eardrum. There we are. I'm going to kind of peel it backwards. So yeah, I'm actually kissing the surface of the eardrum, so I'm making contact with the eardrum, but the patient doesn't feel it at all. Unless you stab onto the eardrum. The eardrum actually is very resilient in that respect. Patients don't generally notice that you are on the eardrum, and they don't report any discomfort or pain. So this is where the hammer bone is the top section, the short process. So I'm just peeling backwards here. And again, there's going to be some layers still there. I'm not going to be able to remove every single layer, because sometimes trying to remove every single layer, you're going to have to be more aggressive, and that's what we don't want to do. We don't want to puncture this patient's eardrum and perforate it. So the anterior portion of the eardrums, so between 12 and 6 o'clock, so where we are now is about 12 o'clock, that part of the eardrum is fully visible. And the eardrum is obliquely aligned in the ear canal. So what I mean by that is that the top left section of the eardrum, so about 10:30 or 11 o'clock, that's closer to the entrance of the ear canal as opposed to the southeast region, so about 4 o'clock, which is more located deeper in the ear canal. So you've got this oblique angle, around 45 degrees even in some cases. So I think I'm going to go back to the eardrum in a moment, but sometimes it's good to have a little break from the eardrum, because obviously, although the fine end is relatively quieter than the ulnar, it's still noise, and so I've decided to just come away for a moment and then just focus on the anterior canal wall. And again, I'm just trying to remove as many layers of skin as I can. When you've got skin that's about to shed, but it's not quite shed, that can be quite difficult to remove, because that's when it's still strongly adhered. Let's see, I wasn't expecting it to be as thick as this. And the fine end is really, really good for these procedures because you've got that precision. Ironically, although the fine end is got smaller internal diameter, when you're focusing on a small area like or a thin sheet of skin, it's actually probably more powerful than the ulnar, because with the smaller internal diameter, you've got a smaller surface area and therefore greater pressure, i.e. suction power. But of course, if you've got a large lump of wax, you do require, although the suction power might be reduced in some respects, but you've got a larger surface area to grip onto. But with skin, it's actually probably more powerful and effective. And of course, it reduces the risk of clarinetting. If I suction this with a full ulnar suction probe, it's very likely that we'll experience clarinetting, which is a very loud, high-frequency squeal. And it's not only very noisy for the patient, it's noisy for myself. Now, I've developed a really bad habit which I need to eradicate, and that is when a suction probe is blocked, obviously you want to know it's blocked. Otherwise, when you're trying to suction earwax, you're just pushing it further in. And I've now got a really bad tendency is every time I come out of the ear with the suction probe, I hold the suction probe beside my ear. It's just so I can hear the suction, and if it's obviously quiet, I know it's blocked. And it's my right ear I'm always doing it against, because that's where I hold the hand. My dominant hand is the right hand. And if I continue to do that over many, many years, although it's not incredibly loud, but even moderately loud sounds, being exposed to it for many, many years, even if it's a short duration, which it is only for a few seconds, but if my ears continue to expose to that, and I'm doing this on a daily basis, no doubt it's going to long-term give me a bit of a noise-induced hearing loss. We do see a lot of dentists and dental nurses who use drills, etc. And many of them also can experience a noise-induced hearing loss. So a simpler way of testing whether the suction is blocked or not is just by suctioning my glove, my examination glove, to see if there's any suction power. But when you get into a habit, it's really hard to break. And what's quite amusing is that even when I'm using manual instruments now, like an ear hook or forceps or correct, every time I come out the ear with it, I'm also holding those beside my ears, despite them not generating any noise, because I've just into that habit. So something that I'm conscious of, and I've got to try and break that vicious cycle now. So just on the front part of the ear canal, the anterior canal wall, it's quite medial. We're near the isthmus, so the isthmus is a narrowing. We have two narrowings in the ear canal, one near the entrance between the first bend, which is about 0.5 centimetre in, and the second bend, which is a further 0.5 centimetre or so in. And then as we approach the eardrum, the ear canal narrows, typically from the front section of the ear canal. That's the part of the ear canal that comes inwards, and then it protrudes back outwards. And that's why we have an anterior recess. That's why the front section of the eardrum, the ear canal in that region, is widened because of the anatomy of the ear canal. Before it comes in and it kind of angles back out again. And we also typically find the floor of the ear canal as we approach the eardrum, that raises somewhat, causing a narrowing, and it dips back down, and that creates an inferior recess, so a basin or a trench. So we've got some skin here that's slightly obscured by the hairs. Now, if I go any further into the ear, past those hairs, it possibly means that that skin will be out of sight. If I come away anymore, I'm just not going to see it. So sometimes, you are compromised with the anatomy of the ear in terms of the hairs and reflections, but you just got to manage that. So we've got this underlayer of skin. I'm just not sure if it's ready to come away. Some of it is, some of it's not. I don't want to scratch this patient's ear. So the last thing I want to do is, if I scratch the ear, not only will I lacerate it, but I'll cause inflammation and possible bleeding. And if I inflame the ear, it's very likely they're going to get more skin production in that region, and therefore accumulation of more dead skin. So now, even with the right correct, if I was to glide it, it's just too adherent, and it needs the suction as well. So the right correct wouldn't be suitable for this even. If the skin was a bit thicker, like some of the the initial layers, then yeah, that would be fine. Just going to the roof. This is quite a long sheet actually. It's quite surprising how much I managed to peel away. So the main cause of fungal infections is humidity and temperature. So if you've got increased humidity, moisture in the ear, so water, and if it's quite warm in there, it provides the perfect breeding grounds for internal fungal growth. So I'm really, really happy with that. I know some of you may not be, but I'm really, really pleased with that, especially compared to how the ear was when the patient arrived. Thank you for watching, guys. Take care, keep well, speak soon. Bye.